Welcome back to Plastic Surgery Untold, the greatest podcast in the world, as voted by us. Today we're talking about secondary rhinoplasties. Some people refer to them as revision rhinoplasties. We have Dr. Weinfeld and our celebrity cast here to guide us through this, because I think this is a very, sometimes very sensitive, sometimes very challenging area. And so super excited to hear about that. But before we get too far into it, let's check what's going on with our celebrity cast here. Travis, kick us off.
Oh man, get to start it off. I don't always get to do that. Well, busy as always. I know you've been working on some things too to expand your footprint even more. As have my partner and I. We just got into a new coverage opportunity up in Michigan. So we're just taking over a pain clinic up there and coverage for that. So the logistics and, talking to our providers, getting everything set up, that's been consuming us for the past couple of weeks, but we're kind of in the home stretch of closing that out and making it happen. And we start there at the first couple of weeks of February. So excited about that.
It's always the exciting challenges.
It is. Yeah. It's funny too. It's like you're climbing this mountain and you're doing all this front end work, and then the coverage starts, and then it's like the real work begins. Then it's the scheduling, then it's the things that pop up. So it's been fun. It's been a challenge.
G-berto, what's new in your life?
Not much new to say, but what I will say is that I'm thoroughly enjoying working at Austin Plastic Surgeon and getting to work alongside yourself and Dr. Weinfeld here, assisting in surgery, which is new and exciting for me.
How much did they pay you to say that?
Huh? A lot. Don't you worry about that.
I'm sorry, who are you again?
And you actually did your first Schmidt facelift a week or two ago. Is that correct?
Well, I assisted.
Yeah.
But yeah, that was
Dr. Weinfeld.
Assisted Dr. Weinfeld.
That was a lot of fun.
That was a lot of fun. It was really cool. First time doing that.
I think, and even as an injector, and this was an interesting comment you made to me, that as an injector, you feel like even some of ththese experiences have made you better. Because it's cool it's one thing to read about, but it's another to see like, oh, well, I was actually in the periosteum. I was at these different fat pads. These fat pads I'm used to fill in. We lifted, moved, shifted, and redid it. So kind of a neat different perspective you were saying.
Yeah,
100%.
That bony anatomy, I think, was really neat.
Dr. Weinfeld allowed me to kind of take a look at this incision that he made, and where he had used an elevator to kind of lift the tissue away from the bone, and I actually got to see like the malar eminence, and it was really cool to see because from an injector standpoint, you see all this stuff in books and illustrations and stuff, but to see it in 3D in real life, it's a game changer.
And you were saying you guys even saw the neurovascular bundle of the infraorbital nerve, and so I think that's really interesting because you hear a lot about when you're reading it and from an injection standpoint, but to see it, you'll never forget where it is. Once you've seen it in person of exactly how far below the orbital rim and where it comes and how it branches out. I think that's super cool.
Yeah. Super excited about all these opportunities that have been afforded to me, and looking forward to applying them to what I enjoy doing, which is injecting.
Awesome. Dr. Weinfeld, what about you? Well, like you've been gone for a little bit.
Yeah. Well, as you guys know, I just finished the Austin Marathon. And by finished Austin Marathon, I mean finished getting through the traffic of the Austin Marathon to get here. So, that was a lot of fun. No, actually, you guys kind of giving me the lay of the land on the way here helped save some time so we get the cakes for Donald's birthday here. On a personal level, we poured the foundation for our house.
Congratulations.
So that's exciting, yeah. So probably be moving in about 3 years, 3 to 4 years now.
You're on pace. You're on pace. But at least you have a house coming in Austin, which is almost like a winning the lottery in of itself.
Oh my gosh, yeah. And we were a little bit unlucky in that we started to work on this process in the midst of the pandemic, but we were lucky because we were able to do it at all. I mean, there's some people who are just having such a hard time with housing here, as I'm sure you guys are all aware.
Yeah. And then to your point, happy birthday, tall gamer, Donald.
Boom.
Dr. Weinfeld last night had messaged a cake. I thought he was kidding and thought it was a great idea, but so instead, tall gamer's got 2 cakes here. I got him a little baby one. Dr. Weinfeld got him a 3-layer super grande chocolate, German chocolate, coconut layers.
Basically, I'll be seeing you in a couple days for fat removal. That's how
I'll
that
refer
works.
to 2 episodes ago. We'll talk about some Eon, little fat reduction here.
Exactly.
Besides your birthday, what's going on with you?
Oh, man. Just really, really focused on South by Southwest. So all fingers, eyes, and everything is crossed that it's going to happen this year. Working towards, I'm actually going to throw a South by event, unofficial South by party. So got my venue all picked out, got the catering and everything. So just out there hustling.
Maybe we'll get an invite.
Yeah, I was about to say.
Yeah.
First I've heard about it, so stay tuned. You guys are hearing it as we're hearing it. Who knows?
Yeah.
We got our fingers crossed and we get an invite.
Exactly. Oh, you guys will be on the top of the list. Top of the list. So yeah, that's been my big focus. Kicked off a couple of new contracts at the studio. So just hammering it out, man.
Okay.
Yeah,
cool.
just loving it.
Well, let's jump into it. You know, when
Also,
we...
thank you. Wait, before we jump.
Sorry.
Thank you all for the cakes and everything in the celebration of my 44th year.
Oh wow.
So
You're looking fine.
well, got to keep up with you guys.
Well, Dr. Weinfeld, talk to us a little bit. What are revision rhino? What's the most common reason people end up coming back for a second nose surgery and even start down this chain, and then we'll kind of talk about what people can and can't do.
Yeah. Well, unfortunately, it's dissatisfaction. And when you introduced the topic, you mentioned that it was a sensitive subject for patients and that it's also a challenging endeavor to try to build upon what has already been done. It's a sensitive situation because, patients are often coming to you because they've had surgery somewhere else and they're disappointed with the results. And that in and of itself is a challenging thing to deal with because you have a patient who's had surgery and they've already come to distrust another professional. And some of that skepticism that they have and even the emotional overlay of that can end up bleeding over to your interaction with the patient. So you need to sort through that with patients initially. And what's really important to know is that all very experienced rhinoplasty surgeons will unfortunately have some patients that are dissatisfied. And it's almost never because a bad technique was used. It's not because a poor execution of techniques occurred. It's really because rhinoplasty, it's a challenging procedure. Surgeons can't control everything. They can't control the way things heal. I don't know of any surgeon that I've ever spoken to or interacted with who has left the operating room feeling as if they haven't done everything they can do. But you got to sort through those issues with patients. And that's just the psychological part, which is about half of interacting with patients to have a successful secondary rhinoplasty experience.
One of the things that I've always found super interesting about rhinoplasties and it can also be challenging is there's the nose that you leave on the table when you finish the surgery, and then there's the nose that patients have 1, 2, 3 years down the road. And I don't think people realize how much things change over time, and you trying to predict where the swelling, how those things are going to settle, fall, and what you can do to support and keep some of those things and things you anticipate. Can you touch base on that? Because I feel like sometimes people don't understand the evolution and swelling and stuff that goes with this.
Yeah, I mean, there's the short-term changes. And when I say short-term, it's actually the long-term changes, meaning at least a year. So that year time frame is the time frame that we tell patients, hey, listen, you can't really judge things right away. Generally, if they like it when the cast comes off, they are going to like it later. But what often happens is that after there's that initial joy of how things look, because usually there's a dramatic yet natural change, then the patient's swelling after the splint comes off, it actually kind of blooms a little bit. You'll get a little bit more swelling, and patients will feel as if they've lost some of the results. And we see some of that swelling come down at about 3 months. About 60% of that overall swelling comes down. But then it'll take another full 9 months in order to get to the point where we feel like it's a stable result. But it's not really stable. As you said, patients can experience changes 3, 4, 5, 6 years out. Now, it's rare that those changes are really bad changes, but sometimes they are. Sometimes what we see is that the overlying soft tissues will thin and it can reveal some of the grafts that underlie it. And then also sometimes we'll see warping of the cartilage. Many of the cartilage grafts that we place do have the potential in a very late phase to bend, and some of those cartilage grafts can even be sort of biodegraded, or they can be resorbed. And all those can create changes that, frankly, the surgeon doesn't necessarily have control over. And so those are the type of patients that we'll end up seeing, and we'll try to counsel them. Hey, listen, especially if you like the results initially, it's not that something bad happened or that the process was a bad one. It's just those things that, neither you as the patient or the surgeon who hopefully had provided you a really nice result can control.
Those changes that you were talking about that happens after that first year, is that mostly continued body healing, or is that like the patient out and about doing something, jostling their face and causing those kind of changes? Or
yeah, I would say it's almost never something that the patient did, especially when we're talking about the changes that you see after a year. It's more sort of biological factors kind of that you hinted to that in some ways you can never even put your finger on. I will say that it is interesting that, for example, if someone has a rhinoplasty, especially when we're moving cartilage around a lot, and then they go on Accutane later, that is just to give you an example of sort of a factor that some human controlled could actually lead to relatively dramatic changes, because there are there are reports enough that we believe that it's true that Accutane is an acne medicine. If you're not familiar with that can make cartilage grafts resorb. Yeah. And then, of course, if someone has relatively major trauma, they can it's like you can break your nose, before you have a rhinoplasty, you can break your nose afterwards. Yeah.
And you talked on it, because I think, I challenge with some of the same stuff with liposuction. This isn't a tummy tuck or breast lift where you're cutting out that skin, redraping it, kind of taking out what you need. You're changing the foundation, and that, draping over the top takes time to refill, settle, and be perfectly to show off the new structure that you've made. And so some of that is the time. Yeah,
that definitely speaks to what we see in that first year, is that really you don't have a great sense of all of the finesse that has been executed in creating a really nice architecture until you get to that year, and that sort of comforter of soft tissue that's swollen turns more into sort of a light blanket, so that you can really see what's underneath it and really have some of that really nice structure reveal itself. And to that end, it's really interesting. Sometimes I'll have a nose that, it comes out of the splint, it's nice and straight, and then you see him back at 2 to 3 months, and it looks like it's curved to one side. And you're like, well, be patient. And then you come back, and then it's curved to the other side another couple of months later. And what I realized is that sometimes people have differential swelling on one side or the other, and it's like a ping pong game back and forth. And I've learned to be very patient with those patients and encourage them to wait till you get to a year. Because if it was straight coming out of the operating room, and it's straight when you take the splint off, and they didn't bump it, something's going on that's probably temporary over a year, but temporary nonetheless.
And to this point, so before you would even start the conversation with somebody about a secondary rhinoplasty, revision, however you want to discuss this, what's a typical time frame that you would make somebody wait before going back?
Oh, definitely a year. I mean, I think that's kind of the industry standard. I don't mind seeing patients before a year. I don't want to see a patient, a month or 2 months after they've had a rhinoplasty by someone else, because I think that's kind of like a panic. They're like, there's something I don't like, and I just need to talk to someone else. Really, that patient should be speaking to their surgeon. But if they're 6 months out and they feel like they're not getting the answers they want, I don't mind seeing that patient. But it's always with the condition that we're not going to even talk about surgery, like not even what we would do until we get to a full year.
Can we talk about, because there's obviously the waiting. None of us want to wait.
Yeah.
And there is this thing of liquid rhinoplasties, fillers, those type of things for the nose. Is that something that people use in this intermediate category? Is that something worth doing? Is that something that you've ever done in your practice? How do you feel about that?
Yeah, I'm glad you brought that up, because I didn't really think about that. There are interventions short of a revision that one can employ before you get to that 1 year time frame that's kind of like a Band-Aid, or camouflage that
Or
a
maybe
patient.
they're just not even ready for a surgery and they're
Oh, I see
after
what you're saying.
a year,
Yeah, exactly. Yeah. But I think that can be very helpful for the patient who is kind of generally happy, but there's like a little concavity somewhere that you suspect is going to sort itself out as some of the swelling around it settles down. And you can fill that with some filler. Hyaluronic acid almost is always the one that we're using, or is always the one that we're using. And that's a good way to have a patient who's generally happy, but has one area of dissatisfaction, a 3-6 month time frame, and really is having a hard time with it until we get to a full year. And that can be a really nice thing to do for someone else's patient, or for your own patient, just to help them be satisfied until you get to the point that it's even reasonable to think about surgery.
But is there a time that if you know that you have a surgery date, something, is there a time? Because I get this question, and I don't do revision rhinos like you do. Is there a time when you shouldn't do fillers if you already know you have a surgery date planned or something? Just for our injectors that are listening, if I have my revision rhino scheduled with you in 2 months, should I see Gilbert and? Because sometimes people don't even know that they won't tell somebody that, hey, I got a surgery scheduled.
Yeah. Well, so yes and no, but I mean, to some degree, mostly no, in that, if a patient's really in real duress about the appearance of their nose and they've got a wedding coming up, but, we're clearly not going to do surgery right before a wedding and certainly not before a year, I think a filler is a great way to solve the problem of the patient going to be interacting with friends and family and photographs. And kind of leaping to the end, we know that we can erase, if you will, the filler, if it's a hyaluronic acid filler, with hyaluronidase, which is an enzyme that breaks down the hyaluronic acid, the filler. And so I don't, I think that, it kind of depends. But I think that's a good strategy to deal with a important social function or just someone who's just really dissatisfied. I like to make sure that we dissolve it at 2 weeks so that if it doesn't all go away, we still have like another week before we can inject it. Yeah, inject the hyaluronidase and dissolve that filler. But I don't think it's the wrong thing to do. I mean, a patient just has to know it's a little bit of expensive camouflage or Band-Aid, but they're getting value for it if they can go to that wedding and feel comfortable.
Sure. So you'll do, just so for people listening, just so that when they're planning their lives, so you'll dissolve it at 2 weeks, probably plus or minus their pre-op with you. Yeah. Dissolve everything. Also probably gives you a good idea to see exactly what's going on if somebody else did the camouflaging or filler.
Oh, yeah. Exactly. I mean, so there's kind of some other questions bundled in that question. If a patient comes to see me for revision rhinoplasty, but they have filler in their nose, I mean, it's very difficult to tell the patient what might or might not be needed, even if they have photographs, because, those are 2-dimensional, bad lighting. Sometimes you can't really tell what you might need to do. It depends on what strategy you want to employ, what the patient wants to do, but it probably would be best to dissolve it for, let's say, this new consult that comes in, other surgeon, secondary rhinoplasty, but they've had, the patch of a filler, dissolve it and have them come back and see again before you make the plans to even do a surgery.
How would you recommend somebody finding a surgeon? Because if you've already had a rhinoplasty, knows something, is there questions that they should ask somebody specifically, just in terms of making sure they're a good fit? I guess, how comfortable they are. Because I feel like a lot of surgeons do primary rhinoplasties. I don't feel like a lot of surgeons do secondary, especially, and we'll probably touch on it when you get into some of the more advanced techniques like rib grafts and other things that sometimes are needed because there's only so much tissue in the nose to work with.
Yeah. Well, I think one way is to ask the surgeon's office. And I think this is one procedure in which the surgeons are really good at sort of self-selecting themselves into doing it or out, and so I know, a lot of surgeons who will do primary rhinoplasty and do it very well in the community, but when it comes to secondary rhinoplasty, end up referring the patients to me, and there's other good people in town, but people who do have experience with secondary rhinoplasty. So as a patient, it's a very reasonable thing to ask, how much experience does the surgeon have as they're considering having a consultation. It's always good to ask for, are there any pre and post-operative photographs that I could look for on the internet? And then, in the consultation, if you end up in a consultation and you're just looking for some more information from that surgeon that makes you as a patient feel comfortable, it's very reasonable to ask, what's your experience with, ear cartilage or auricular cartilage grafting? What's your experience with rib cartilage grafting? Is there anything that you feel concerned about with my particular nose? Does this fit into the wheelhouse of the level of difficulty that you feel comfortable with? Because I think we're very fortunate, especially in this community, with a lot of very honest, very skilled plastic surgeons. And if someone ends up in their office and they just don't feel comfortable with it, I think they're going to say that that's the case.
I got a question that, Johnny, you kind of touched on when you said that there's only so much tissue to work with in the nose. Like, what can be done on the second time around? Like, once you have a major rhinoplasty, like, what sort of things can patients expect to be done, or can't they not do any longer? Or
yeah. So in a primary rhinoplasty, we're almost always moving cartilage around. And what that does is that helps reposition tissue to resist some of the scarring forces that can occur in the long run and distort what the result would otherwise be without putting those chunks of cartilage where they need to be. The need for that is even greater in a secondary rhinoplasty, but unfortunately the supply is not present, because the supply we get in a primary rhinoplasty is the septum, the midline wall between the two sides of the nose. Wonderful source of cartilage. You're essentially repositioning cartilage in the nose to other places in the nose, and you get really good results. But when that septal cartilage has already been used in a primary rhinoplasty, you have to go to these other sources. And I think that's what Johnny was referring to, or I know that's what Johnny was referring to. And so the two sources that we go to are the ear, small incision behind the ear, and remove a small segment of cartilage that rests against the skull, if you will. So you don't even really see it. It's not the ear part of the ear. It's really the part that you don't see. And that cartilage is flexible, it's thinner, and it's not that abundant. So I like that cartilage when I don't need something that's that strong, when in fact flexibility plays into what's going to be a favorable result. And again, when you don't need that much. And a great example for that is if you need a very small tip graft, that cartilage is great for that. Whereas rib is more abundant, it's more firm, and it does have it's stronger. So when you need structural grafts in order to really keep the nose pushed out against the skin to create a structure that you have designed to make a patient happy, that's where you go to the rib cartilage graft. So a good example for that is a spreader graft, sometimes a columnar strut graft, but that's not very good. For sometimes, I mean, this is, I'm speaking generalizations, but that's not quite as good for a tip graft because it's so firm,
right.
And it's really pushing out on the skin, and the skin may later thin over it. And you may see some of those grafts. So, but I don't want people to leave with the idea, as really important, that rib cartilage is wrong for the tip, because in many situations, in some unique situations, it's important, like cleft rhinoplasty, when you're just not going to have enough ear cartilage and you really need something strong, or someone who has thicker skin. But again, in general, two different types of cartilage, two different properties, serves two different purposes.
Especially when people are on multiple revision rhinoplasty, they run out of choices, and that's where someone like you may have to go to a rib, even if that wouldn't have been your number one choice, because if ear, septum stuff have been used, that's where...
Yeah, that's what you see when you've seen patients who, they're having a tertiary rhinoplasty. They often have had one or both ears used as a donor site, and that's where you're definitely going to be going to the rib. I think that speaks a little bit to the choices sometimes. I think that sometimes surgeons will resist going to the rib because it is a little bit more invasive, and who wants a small scar any scar on their chest, but a small scar on their chest.
But you're not giving yourself enough credit here, because I'll tell you, I've done a few rib cartridges, mostly when I was in Miami and in training, and mostly for traumas where people just got their entire nose crushed from these traumas, and then needed a lot more than you'd be able to do with normal stuff. But your technique where you do this tiny incision, almost right at like where the fold would be for a breast type stuff, is super unique, because very few people do such a tiny incision for a rib graft cartilage. And it's almost a little bit, anyone who's ever watched one, and you have some on your Instagram stories, but it's cool because you take rib, but what you actually whittle down to actually use is pretty small. And so it's cool that you make the incision incision's tiny, and basically take what you need and then shape and use that. So one of these days we got to put this on a little YouTube video or something, because your technique is actually unique and actually super cool how much you do through a baby incision.
Yeah, no, I appreciate that. And I have to give a little bit of a shout out to Dean Toriumi, who at least you're probably very familiar with as an expert in rhinoplasty. And he showed a video where he was taking, rib through a very small incision. And it really encouraged me, especially on thinner patients where it's possible and safe, to really shrink my incision. And I've got a whole setup, the way I do it. I actually use some of the rhinoplasty retractors like the Alpha retractor, and the way I position the bed and the headlight and all of that. And it works out really well. That's why it's great to go to meetings, right? You see things, you're like, wow, I can or I should and can be doing this. And you push yourself to do things better for the patient.
I remember, just as an anecdote, I remember the first time that we did one of these together, and you were making the incision and I'm watching. And up to that point, I had done a couple rib graft harvests, but it was, doing trauma and doing bigger, complex crush injury type cases. This is a cosmetic young girl, and we're doing her, and I just remember the incision was tiny, yeah. And all of a sudden you just pull out this monster piece of cartilage, and I was like, oh my God, where did that come from?
Yeah.
And everybody in the room,
it's a boy.
Yeah, exactly. We named it and weighed it. No, but yeah, I think people that are listening to this as a layperson can't understand, the finesse and technique and the amount of experience that you have within the confines of, revision or secondary rhinoplasty or even tertiary rhinoplasty. I mean, it's a different ballgame when you are, when you go to a mechanic and you open the hood and it's not factory parts that are under there, it's other pieces and it's somebody else's work and reconstruction that they've done on that engine and parts that they've imported from other places and other techniques that they've used to get there. And then all of a sudden you're opening it up and you're like, okay, well, I've got these tools in my toolkit. How can I rebuild this engine to be a good, or to house a good nose, right? So hats off to you.
Yeah, no, I appreciate it. Thank you. Yeah, what's so interesting about it is you kind of spoke about opening the hood and it's not factory parts. It is interesting. I find it very interesting to see the nose from the outside, see some of the really objective flaws that exist, and then open it up and start to discover it. It's almost like you're a detective, and there's like a forensic nature to figure things out. And kind of think through what might have been some of the unintentional pitfalls that someone fell into, or how things probably, like, you look at it and you're like, I see all the makings for success, but something's out of place. Did the patient scar in a way that no one could have anticipated, or was there maybe trauma after the fact that
Sure.
that this they weren't aware of. So that's really an interesting aspect of it, and like clearly seeing the physical nature of the nose under the skin in a secondary context definitely makes you better, because you're like, well, I need to be making these grafts a little bit larger, or I need to place them in a slightly different location. But what's also interesting, and it kind of goes back to the sensitivities and the emotional aspect of this, and this is almost like a PSA really to patients and to plastic surgeons. The one thing I've recognized in interacting with patients who are seeking a secondary revision rhinoplasty is that it is really essential for someone who's going to have a primary rhinoplasty that patient has to come to the decision to have rhinoplasty with their own idea and their own vision of what they want. If it's, my mother was suggesting this, or my mother never liked that, or my father said I had this, or my boyfriend or girlfriend, suggested that, they like, this or that look on me, or another one is, I went to see a surgeon and he made this suggestion, she made that suggestion, or I didn't really know what I wanted. I just wanted my nose to look better. Those are the kind of comments that I hear from secondary patients.
Sure.
Here, that's part of the unfortunate recipe that led to dissatisfaction. And so now, if I have a patient comes in and is like, I just don't know what I like about my nose, I'm like, well, you need to.
Yeah.
You need to know what
Yeah.
you don't like about your nose, because I can do 1,000 different things, but I should only do one thing. And that's the thing that when you look in the mirror, you don't like, and so I will resist making suggestions initially. Clearly if a patient is saying I like this and I like that, and I'm like, well, to do that, I'm gonna have to do, this and that to go along with that, but you have to first have like the sense of what are the three big things you want to have changed. I force a patient to do that, and I'll tell them, go to the internet, find photographs, look at my pre and post ops, show me someone else's pre and post ops, find a movie star, whatever you can do to articulate to me what you want changed, you're going to have to do that and come back if you don't have a clear sense. And I've done that with patients on multiple occasions, and sometimes they're the happiest patients because you've just forced them to tell you what they don't like. And they kind of, and what you realize is that they do sort of have a sense what they don't like. They just can't express it, but it's such an important part to have them be able to put their finger on it, put their eye on it, articulate that to you, advocate, take some responsibility for the choices of having surgery and what they want to have look like. That is a great recipe for success. So patients thinking about rhinoplasty, force yourself to do that. Early plastic surgeons, young plastic surgeons, getting into this wonderful field of, rhinoplasty surgery. This is a really important emotional, psychological recipe for success.
It's hard for us to have a vision that matches their vision if we've never even seen or heard what their vision is.
Wait, you're not telepathic?
No, we can't make the journey there.
Well, that's a little bit of sort of a lead for talking about one of the really nice technology tools that we have introduced in the office. So, it's interesting you talk about telepathy, right? So I talk to patients about this, like we need to triangulate, me and a patient. So Travis, patient, is like, you have a vision. I know you do. It's in there somewhere. You've told me some things, but your vision's probably much more rich than I'd be able to even understand by just talking about those three big things. And like, I have a vision and an understanding for your vision, and I also understand what's possible. And we need to triangulate somehow so that we can communicate, with pictures, because pictures, as we know, are worth 1,000 words. And when it comes to rhinoplasty, probably 1,000,000 words.
Sure.
And so we have a really wonderful tool called Chrysalix. It's a three-dimensional morphine software that we can use there's a lot of different modules for it that we can use for breast augmentation and for breast lift, I believe, and even, some facial fillers. But it's really nice for rhinoplasty. It's not perfect, but it's really nice. And what we do is we take three still images, and then the software ends up assembling those into a three-dimensional image. And then there's certain sort of procedural modules that we can use to narrow this part of the nose, widen that part of the nose, turn the tip up, turn the tip down, bring the dorsum and the tip back. Again, it's not perfect, but it's a really good thing, and we can do this in front of the patient, and so they have some control over it. And they can also say like, "Well, I want it smaller." And we're like, "Well, you can't." Like if we do that, it's just I can't physically make that happen, or if I could, it's going to make your breathing not as good as it is now. So it's a wonderful tool to do that triangulation, to have that back and forth telepathic communication about what can be done, what should be done, what I want done.
I love this because this is with our breast stuff too. It's like our BBLs where somebody wants something, and I'd rather them be disappointed at the consult when you're showing them a picture than disappointed 2 or 3 months after the surgery. Because to your point, there's some things you control, some things you can't. Somebody's thickness of their skin, if somebody has much thicker skin, there's a limit to how small you're going to make that nose. There's just a limit to some of the things that you can change without causing real problems for them.
How do you tell the thickness of the skin before you even
honk, honk?
I mean, so some of it's based on just the experience and looking at someone's nose. Obviously our fingers can really help. There are definitely, ethnic and racial differences that you can kind of help inform your understanding of what, the thickness of someone's skin is going to be. And then there's actually some surgeons, I've not done this yet, but some surgeons are experimenting with ultrasound. And so it's another way that you can get they're using it more for sort of experimental purposes to kind of get an understanding of how it can work as a tool. So it's in no way the standard of care, and not having access to that now does not in any way limit my ability to do a good rhinoplasty. But, there are things on the horizon that we might get into.
Right on.
But it's mostly experience, observation, touching, looking.
This is making my nose itch, this whole conversation.
What would you say are the most common, like if you had to pick like a top 3 reasons that people come in for secondary rhinoplasty, is there any kind of common things that you see?
Yeah, tip irregularities, so a twisted tip, an asymmetric tip, that would be number 1. And usually that happens from over resection of the cartilages, which are the lower lateral cartilages that make up the tip structure. And so if the portions of it are over resected, then they just don't have the strength to support the skin that's overlying it. And you end up seeing one area buckle in, or you see there be a twist. Twists actually occur, interestingly enough, if you try to bring about too much tip projection in a nose where the skin just won't permit it. So if you have a tent where the tent flaps are kind of limited and you try to like hike a pole up into it, it's going to start to bend, and that bending in the context of a rhinoplasty is those tip cartilages sort of buckling, bending, twisting, and you can see that in the tip. The second one are dorsal irregularities, so sometimes I see this a little bit more when I'm doing a secondary rhinoplasty for someone who's had a closed rhinoplasty. Not that it's a bad technique.
When you say dorsal, what do you mean by that?
Oh, thank you for asking. The bridge, yeah. It's, from where the nose takes off from the forehead between the eyes down to just before where the tip begins. That's the dorsum, or what we discuss at least as the dorsum. It's made up of cartilage in the upper half or upper third. Bone in the upper half or upper third, cartilage in the lower half, lower 2/3. And so you can get irregularities there. You can get irregularities where there's a portion of cartilage that's sticking up. Sometimes it's that either the dorsum wasn't evenly resected, or even some of the grafts that we put in. I've seen this even in my own patients, once or twice, where one of the cartilage, the spreader grafts will pop up, usually further in the back. I think sometimes accidentally little pieces of cartilage are left behind. So we try to rinse that cartilage out, but sometimes you're not able to get all of it out, and you can, as the swelling goes down, you can see a little it's essentially like a little scrap of cartilage. Where you can also see in the upper third, upper half, irregularities of bone resection or rasping. And then another sort of category, more challenging one in the dorsum, in the bridge, is what we call an inverted V deformity, where the bone is stronger, upper third, upper half. The bone is stronger, the cartilage is not quite as strong. And so if the cartilage has either been over resected or is poorly supported, usually in the absence of spreader grafts, or the stitches that were trying to hold it up, were being used to hold it up, resorb too early, you can see the cartilage recessed, and you end up seeing the bone above well supported, the cartilage below, and you see a shadow there called an inverted V deformity. So there's the dorsum, and then nostril asymmetries sometimes are another one. And I always tell patients, nostril asymmetries, like everybody's nostrils asymmetric. You don't notice it beforehand. You notice it afterwards. Yes, surgery might have exacerbated. Yes, there's some things I can do, but please don't expect that I can make your nostril symmetric, because it's almost impossible.
Is there a situation to where like a patient will come in and say, "Hey, Dr. Weinfeld, I want X, Y, and Z," right? And you use the 3D software, you give them a look of what it might look like. But is there a situation to where you can say, "Hey, go see my friend Gilbert," and through fillers and whatnot, we can kind of give you a real world idea of what your nose will look like? Like, is that a thing?
Yeah, absolutely. Fillers are really wonderful, and they work really well in some specific areas. In particular, they work really well in the, and I'll speak to my experience and understand. I think we should have Gilbert chime in as well. But they work really well, really in the upper third of the nose in a very specific situation. And that is, if someone who has a small hump on the dorsum, which really is because or part of the reason it is there, or part of the manifestation is that actually the upper third of the nose overlying the bone is a little bit recessed. Adding filler there is a really wonderful way for a patient to see what it might be like to have a rhinoplasty and put a little bit of a graft there we call a radix graft. So yeah, I think that's very helpful. And many patients just choose to have that done instead of surgery because at least in the short term it's less expensive. Recovery is almost nothing. Risk are pretty low. And so yes, that's a very helpful thing to do. And yeah, fillers for these type of, as an alternative to rhinoplasty is a great way to sort of date the result before you marry the result. Yeah. So, and I think that's kind of what you were getting at.
Yep.
Yeah. Gilbert, what do you think? Any other areas where where that can be quite helpful. Fillers can be quite helpful.
So from my own personal experience, I recall one patient in particular who came in for a consultation because she had had a rhinoplasty done and had some areas that she was not terribly enthusiastic about with the results. And so we used some filler to kind of help alleviate some of those. She was super happy in the end. I was really excited with the results, but essentially what she had like a little indentation, kind of to piggyback on what you're saying about maybe the dorsum being rasped a little too much.
Yeah.
And so she had a little indentation on the dorsum of the nose. She also had like a little notching to one of the nares that she wasn't too crazy about. I was able to soften that a little bit with some filler, but I wasn't able to, eradicate it completely. But she was not very enthusiastic about having a secondary rhinoplasty done. So this was a good intermediate step for her.
I like your choice of words, not enthusiastic.
Yeah. Well, I was thinking about that as he was saying that, and I've been very careful too, also to really kind of relay the way that I try to interact with a patient. Patients will often come in angry at their surgeon, but in some ways it's really not justified anger or dissatisfaction because, as we were talking about before, there's a lot of factors that can go into a result not being what the patient wants. And if you in any way sort of unintentionally say something that reinforces the patient's perception that the surgeon did something wrong, you've in no way helped the situation.
Sure.
And in fact, in some ways, you're making it more and more challenging for that patient ever to be happy with whether it be filler or surgery, because they feel as if they've been wronged. They have this, they have this sort of this essence, this trauma that someone did something wrong to me. And they're, it's not like they're going to get an apology from that person because one might not even be, appropriate. But there's something like in their psyche that is going to make it difficult for them ever to be happy. And you can't have a cosmetic surgery won't make people happy. They have to be happy before surgery and they'll be happier after surgery. But if you have an unhappy person, even if it's very focused on their nose and the experience of their primary rhinoplasty, if they're unhappy going into surgery, you can't make them happy. They have to have come to peace to it. And if you're even, unknowingly bad mouthing someone else, which we would never do, but in some way, if you say anything that would lead to the perception that the surgeon did something wrong to them, you're just going into failure also.
Yeah.
So I think you've been very careful about it. I think it's probably based on experience. The way you speak to these patients helps lend to a secondary success, whether it be fillers or surgery.
100%.
Because you mentioned it at the very beginning, like nobody leaves saying like, oh, this nose is off, but I'm tired, peace out, and that's why I always tell people on average, this surgery takes me X amount of time. Sometimes it's a little shorter because everything's perfect. Sometimes like for me, for a breast, if I got to sit you up 6 times, then I got to sit you up 6 times. Same thing. Like if you got to refill the top of that nose, 12 times, you do it. So we don't leave until we're super happy. So it's not like, somebody left and like, it's off, but oh well, better luck next time. So that's not the case. Yeah. Second part, I just want to make sure people hear, because you've both said it, the dorsum, this top part of the nose, is an area that tends to improve with filler. Once you get away from the top 2/3 of that top of the nose, I feel like it's really hard and you got to be really careful with filler, because then you do get worry about intravascular injections if you're trying to do some stuff in other areas, because there's only specific spots that we can put the filler in safely. I think tip of the nose is a really hard one. You mentioned it, skin compliance with filler. Yeah. I think once you get off the dorsum, you got to be really, really careful. And you guys both said that. I just want to make sure people listening hear that.
I agree. You do have to be much more careful with the tip of the nose, especially, let's just say the lower thirds, because it really includes the ala too. And you have to be much more careful, especially in a secondary. In someone who's had surgery before, because there's going to be scarring, there's going to be decreased vascularity, and I don't know. I don't know that this is like a debate in any way, but I kind of think that the problems that you might have in the tip of the nose from injecting the tip of the nose, you know, like perhaps some skin slough, maybe a little bit more due to the pressure created and sort of a pressure related ischemia, almost like a pressure sore that we see in, in people who are in wheelchairs, let's say, more so than intravascular injection. I don't know. And someone might say, well, that's not true, Adam, but I think that might be the issue a little bit more than actually intravascular injection, because the blood vessels there are so tiny,
almost like a compartment syndrome.
Well, 100% like that's another perfect way of describing that. Yeah. So what I'll do for patients, because I've had patients where it was exactly the area that Gilbert had stated. Sometimes you'll see a little bit of a notch in the segue, which would be a smoother segue from the tip out to the ala, and that can be very distracting, makes the nostrils look asymmetric, and injecting a little bit of filler there can be helpful. But every time that I've done that, I've always done it in two. So you put a little bit in there, and so kind of that process of tissue expansion, and then you have the patient come back a week or two later, can add a little bit more, and I found that to be helpful and knock on wood, safe to this point, and also not entirely successful. That's an important thing to tell a patient. This can, if, I like to speak in percentages now because patients, I think, really can relate to it. I probably can make this 60, 70% better. And I think patients, so long as they know that going into it, can be happy with something like that instead of surgery. Yeah.
This skin expansion, I want to, because this has changed, and I feel like I've changed my perspective of this in nose, lips, but there's just a limit, breast stuff, like what you can do in one setting, because to your point, if you try to over expand something that the skin just can't handle, you're setting it up for problems, frustration, and disappointment for all of us.
Yeah.
I got it.
No bounds, please. Yeah.
I was gonna say, so just going through everything that we've discussed, like this question popped into my head, like when we're talking about the nose and we're talking about breathing, that, all of this stuff. Is there anything different that you as an anesthesiologist have to do when someone is doing a revision because their nose may not necessarily be like it was, or like?
No, I mean, there's really no difference in the anesthesia between a primary and a secondary or tertiary or, a 15th rhinoplasty. For us, we do these under general anesthesia. We place a breathing tube because we're working above the vocal cords or above the airway. So anything that we do, blood, fluid, we rinse the nose out several times during the procedure. So anything that we do above just drains south, right? So we don't want any of that going down into the patient's lungs, which is why we place that breathing tube and secure the airway completely.
Yeah. But this is a plug for Travis and his colleagues who do a really wonderful job. And we're very lucky with where we are at. My past experience with him and then some of the other anesthesia providers is that I would say, and I don't think I'm overestimating this, that about 20% of the result has to do with the quality of the anesthesia that's provided. And these are I'll just kind of list the ways in which it's important. One, having a patient's blood pressure be at normal or maybe slightly below normal can decrease bleeding and bruising. And decreasing bleeding can decrease, what I meant to say was bleeding and swelling. So if you have less bleeding, you can see much better and you can make your precise maneuvers as precise as you want them to be. And also, if there's less bleeding during the operation, there's going to be less bruising often underneath the eyes later. So that's one important thing. Blood pressure being normal, slightly low, and not fluctuating. Sure. That's another thing. Another thing is managing a patient in a way so that they are not going to be nauseated after a surgery. Mm-hmm. If a patient retches or throws up after a surgery, especially in the first couple of hours or even the first day or two, they're going to have more bruising, again, underneath their eyes. And then what also can happen, and this is very challenging for us to control, is that if they have that sudden increase in pressure and they bleed a little bit underneath the skin, they might have more scarring and it might obscure some of the architectures that you're trying to have be revealed through the skin. And so I think that is an important thing. And what's really interesting? Sometimes I'll come back and I'll be doing a revision rhinoplasty and I'll look underneath the skin. I'm like, there's a crap load of scar here, you know, and then I'll start to think, well, wait a minute, this patient's kind of oozing a little bit more and this is a little bit of a tangent, but they're oozing a little bit more for me. And I start to wonder, they have a little bit of an undiagnosed coagulopathy, meaning that their blood doesn't clot as well, or a problem with their platelets. That's a quick tangent, but nausea, managing nausea is really important. And then one thing I would say that's ever so slightly different for a revision rhinoplasty in which we're going to be using rib is that I always ask for the patient to be, and this is like technical stuff that you probably maybe want to add a little bit more about, but I like the patient for most facial surgery not to be breathing on their own, because I think when their patients are breathing on their own, for whatever reason, they bleed a little bit more. But so we ask that the anesthesiologist be doing the pumping the air, anesthesia provider be pumping the air in, pumping the air, you know, pulling the air out, instead of the patient being asleep but spontaneously breathing. It's really important if we're taking rib, because, you know, when we're taking rib, we're working right above the lung, and there's a thin lining in between. And sometimes you get a little tiny hole in that thin lining. Absolutely not a problem whatsoever. And you may not even know about it, and it really doesn't matter. It's not an injury to the lung. It's just it's just like a little tiny hole. Now, if Travis or whoever the anesthesia provider is who is present, if they're pushing air in and out of the lung, it doesn't create a problem. But if the patient is breathing on their own, the way that the mechanics of natural respiration occurs, they're going to pull air through that little hole. And it's a little hole, it forms a little valve, and they collect more and more air with each spontaneous breath. And it can actually lead to a pneumothorax, which is a collection of air around the lung, which can hinder after surgery the full expansion of it. So that is one minor. For me, it doesn't matter, because I'm always asking for the patient to be ventilated versus spontaneously breathing. But I think for other surgeons who might not care about that as much, it's really important if you're harvesting rib, in my opinion, for the rib harvest portion of it, to have a patient being ventilated versus spontaneously breathing.
Yeah, no, I mean, first of all, thank you for that. You know, that's why we spend so much time at our business, like really working with the anesthesia providers that we bring on, and we do a lot of plastics in our practice. So we know the game inside and out for these procedures. So I'll tell them, like, hey, you know, if they're going to be harvesting graft or harvesting rib graft, like, you have to mechanically ventilate the patients. They need to be paralyzed. We need to be mechanically ventilating them to prevent, you know, a pneumothorax developing. It's kind of, you know, more high level stuff that we can get into the weeds on. But for our purpose, you know, that there's a reason that we take that time and effort. And I realize that, you know, blood is an irritant, and a lot of patients, a lot of lay people don't understand that, like, blood in a cavity space or in a space in the body is an irritant. So that is going to lead to more scar tissue in that area. More development of scar tissue means that that's not going to heal exactly like it would have if there was an absence of blood in that area. So, you know, it's little things, and realizing that, you know, when I was at the big hospitals before in my training and everything, there was this very adversarial relationship between anesthesia and surgery. And it was like, oh no, we need to keep the blood pressure up. And the surgeon's like, no, I need it lower and whatever. And it's like, there's this great space that we've found with our business. And you know, in my practice in general, is like, I've got a great relationship with all the surgeons that I work with, because we're there for the same reason. Like, we want as good of an outcome as we can possibly achieve as they do. And our only purpose being there is to keep the patient safe and comfortable, and to provide perfect surgical conditions, or as close as we can to. So when we're thinking in that regard, you know, if Dr. Weinfeld's asking, hey, I'd really like to keep this blood pressure on the low side, if possible, to decrease bleeding, I'm gonna say, hey, that's perfect, but just know she had a history of a stroke, you know, 10 years ago. It's all resolved, but I do need to keep her, you know, between about 100 and 120 systolic. When we have that understanding pre-op, like, there's a lot that goes on behind the scenes between me and Dr. Weinfeld and Dr. Franco and the other guys that we work with that is behind the scenes that the patients and a lot of people don't get a chance to.
I think you touched upon an answer to a question that Johnny had earlier, and that is, how does a patient know that they're interacting with someone who has experience with revision rhinoplasty? And I think a good screening tool, a good screening question would be, doctor, what is your opinion of spontaneous ventilation versus mechanical ventilation during rib harvest?
Damn. That's next level questions. Write that down next to the patient. On that note, is there any last take-home stuff? And I know there's a lot more revision rhino stuff, and maybe we'll have to circle back to this because we didn't even get to some of the sequelae for functional breathing and stuff. Sometimes when the nose is overdone stuff,
yeah.
but maybe we'll say that for another day because we've run a little short on time here. Any other take homes for revision rhino that you'd like patients to know, think about from this podcast?
Yeah, I mean, I think one in a primary rhinoplasty and certainly in a secondary rhinoplasty, make sure you articulate what it is you want to be able to achieve with your nose. Make sure that the surgeon really understands that well. Photographs and even imaging software can help with that. And then also, I think be patient. Don't panic. Wait that full year before you decide how you feel about the nose. That's another one. And also, be reasonable headed into things. When you tell the doctor, I'm not expecting perfection, you got to believe that also, because if you are expecting to be perfectly symmetric, there'd be no little asymmetric shadows or little things that you can feel. You'll probably be disappointed. But if you have really good expectations heading into it, it's going to be a success.
Awesome. Well, I appreciate it. Before we wrap stuff up, do we have a quote of the day?
Let me see what I got lined up for us.
Oh,
how about this one? This is from Roy T. Bennett. Your hardest times often lead to the greatest moments of your life. Keep going. Through tough situations, build strong people in the end.
I feel like we can all kind of relate with that over the past couple of years.
Oh, yeah.
Oh, absolutely.
Definitely been challenging for everybody. Dr. Weinfeld, appreciate you walking us through this, I think, very challenging and sensitive subject for a lot of people. And
Thank you for having me.
Definitely would like to circle back, and we'll see your time again, because we didn't even get to talk about some of the functional sequelae and stuff that can be done for that. And I think, and that for people listening, breathing, others, things like that can definitely be an issue for people sometimes. So we'll put that on the calendar.
Be glad to.
Yeah,
Thank you.
that's awesome.
Well, thank all of you guys for being here. Happy birthday again, Tall
Happy
Gamer.
birthday.
Happy birthday.
We're definitely going to enjoy some cake here in a little bit. But thank you all for listening to Plastic Surgery Untold, greatest podcast in the world, is voted by us. Download us anywhere you get your favorite podcasts: iHeart, Pandora, Spotify, and you can watch us on YouTube as well. So we'll see you guys. Thanks.